So as a part of sympathomimetics, we also have the beta-2 selective drugs. So these are also drugs that are likely to work on the adrenal receptors, only that they are more selective to the beta type 2 receptor. So they have significantly beta-2 selectivity and are widely used in the treatment of asthma. This is because they are better effective as inhalation or oral administration drug. And again, they also have a long duration of action. So this can be further subdivided into short-acting beta-2 agonists and long-acting beta-2 agonists. So remember in our introductory part where we suggested with the sympathomimetics, specifically the adrenoreceptors, the short-acting are mostly preferred for maybe the symptoms that are just presenting. So maybe for emergency resolution of the symptoms, you want that which act short, and most of the time these short-acting drugs tends to act rapidly. And we also have the short that is normally used for preventing feature recurrence, especially if you are dealing with an individual who have had increased episodes of asthmatic attack. So those are the individuals that might benefit from preventive therapy. So the long-acting beta-2 agonist can be used as a preventive, so to prevent future asthmatic attacks. So on to the short-acting beta-2 agonist. So a major example over here, we have salbutamol. So salbutamol is also referred to as Ventolin. So Ventolin is the major brand associated to salbutamol. So this is a specific beta-2 adrenoreceptors stimulant that is likely to act on the beta-2 receptors in the bronchioles, and they majorly have no effect on the beta-2 receptors in the heart. So this is a good thing that it is highly selective to those that are just there on the bronchioles. So it has a half-life of around 4 hours and cuts faster when given, not cuts, but acts faster when given via inhalation, and the effects last as long as 4 hours, so that could be impressive. So this makes it suitable for prevention and treatment of the asthma, having that it can have a long duration of action. But you remember in our statement, we suggested that inhalation, those that are in inhalation preparation normally used to relieve attack. The tablets or the oral are good for prevention. Not that these are the first line, but if you are to compare the two, so this one will prefer it for the prevention, and this one inhalation to relieve an acute presentation of asthmatic attack. So mechanism of action, so just as we suggested with the beta, or rather with the adrenal receptor agonist drugs. So salbutamol likely to stimulate the beta-2 receptors in the lungs, and this will eventually cause the bronchial smooth muscle to relax. So remember, in the bronchoconstrictions, we are dealing with a constricted or a contracted muscle, so we actually require some form of relaxation. So how is it able to do this? Once the beta-2 receptors has been stimulated, this is able to increase the number of adenylate cyclase, which will in turn increase the number of CAMP. The CAMP, through some many other enzymatic processes, is likely to give us some bronchial smooth cell relaxation. So what about the pharmacokinetics? Absorption. After inhalation, it is gradually absorbed into the respiratory tract. Most is swallowed to facilitate the GIT absorption. Action begin in 5 to 15 minutes and peak occur within 30 to 2 hours. So that is when taken through the GIT. And last between 3 to 6 hours. Oral dose is well absorbed. Action begin in 30 minutes, peak in 2 to 3 hours, and might last for 4 to 8 hours. So considering this prolongation of action for around 8 hours. That makes it a good drug for prevention, where individuals normally tends to take around 4 times in a day. So they have a longer duration of action, usually 4 to 6 hours, because they are not inactivated by enzymes such as the catechol or transferase, which were very active when it comes to things like other catecholamines such as adrenaline. So that is one of the major advantage. Does not cross the blood-brain barrier, metabolize into the liver into inactive compounds, likely to be excreted in urine and in fecal matter. So what are the indications for salbutamol? Of course, the obvious things that are likely to present with some bronchospasm. So these include asthma, sometimes bronchitis, chronic bronchitis, emphysema, bronchiectasis. These are things that are likely to limit the airway. So it can also be very important in the use in the premature labor. This is because it also has some tocolytic effect on the uterus. So it can actually allow the uterus to relax. So therefore minimizing labor that normally present with extreme contractions of the uterus. So while using these drugs, you need to avoid concomitant use with the CNS stimulants, such as methylphenidate. Precautions, those who are hypertensive, so remember you are dealing with an agonist this time round and not beta blocker, so they can actually increase the heart rates and worsen the hypertension. Myocardial insufficiency, thyrotoxicosis, beta blockers. So beta blockers might minimize their action, or even in some individual, it might also cause some bronchospasm, of which that might bring us the opposite intention of what we want to achieve with the salbutamol. I need to be cautious in concomitant steroid administration, even though in the practice you'll find this being given. Elderly, because they tend to be sensitive. So in elderly, you reduce the dose. Those who are allergic, so sometimes you can have those who are allergic to salbutamol, so you need to be cautious. In diabetes mellitus, you need to be cautious. So remember, this is a beta agonist. Remember what happens when something like liver is stimulated. So they can be stimulated by sympathetic nervous system, or because they're having some beta receptors to break down glycogen, and that might increase glucose. You also need to be cautious in those who are pregnant and those who are lactating. So contraindication, threatened abortion, and those who are using monoamine oxidase inhibitors. So these could be some drugs that are normally mostly common in use in depression. What in terms of preparation and dosage? So we have various forms. So we have tablets, syrups, and we can have those as an aerosol form for inhalation, and we can also have solution for nebulization. So these are the specific dose. For example, tablets, you can have a tablet of 2 milligram, 4 milligram, 8 milligram. So 8 milligram is normally for slow release, that is likely to be used for preventive. So the normal dose is normally 4 milligrams. So that is a standard adult dose, 4 milligrams, that can be taken 3 times or up to 4 times in a day. And of course, we know this is age dependent and also weight dependent. So you just need to remember that we have inhalation and nebulization. And we suggested that you might want to nebulize a patient with still salbutamol or Ventolin when maybe the inhalation is not working, because we agreed that using the nebulization mechanism or means, it might deliver drugs at a higher dose. So that we should be able to remember. So nebulization as an inhaler. So this is normally a submitted aerosol that delivers around 100 microgram per puff. So this you should give around 1 to 2 puffs after every 4 hours to a maximum of 3 doses. So this is very essential so that maybe the patient does not overdose. So the number of puffs should be very important. And we suggested that this can also be dependent on the brand that maybe the patient will have. So it is very good maybe for you to be aware of maybe what does one puff contain in terms of the microgram. Sometimes it could be containing 200. So if it's 200, the patient might not need to take 2 puffs. They might only require 1 puff. So inhaler can also be good for, mostly it is normally good for acute attack. And of course, after you've arrested maybe now the acute episode, so maybe briefly for up to around 3 days, you can still extend that therapy to prevent future attacks just briefly. So this could be 2 puffs 3 times a day or QID. So for example, you are having a patient presenting with features of asthma attack. You might, if they do not require nebulization, you might give them their inhaler, or you might administer an inhaler where maybe they can be given 2 puffs, and maybe you can repeat maybe after 15 minutes, and maybe the situation might be resolved. So how do you proceed from there? So if that is the only occurrence, and maybe you've auscultated and you've resolved that the inhalation has adequately addressed their presentation, so you can go ahead and maybe prescribe the inhaler drug for maybe up to 3 days consistently, 2 puffs 3 times a day for maybe 3 days. So after there, if there are no attack, so maybe they can just leave it and use it again when necessary. But when it keeps on recurring, you might need another compound. So we'll be able to just give a layout in terms of the algorithm, how we are likely to proceed in terms of treatment. So this can also be very important in those who are known to have an exercise-induced asthma. So they can be, you can recommend 2 puffs before the exercise, especially when the exercise is necessary due to maybe sports that are the only, or necessary because of exercise being maybe a therapeutic modality. So these are circumstances where you might not advise the patient against exercise. So what do? You give drugs, specifically the Ventolin, 2 puffs before the exercise, and now they just carry on with their normal activity. Of course, they need to practice some cautions. This can also be available in injection, even though it needs to be given when the inhalations and the nebulization maybe are not working. So given when the patient has a severe attack and they are not responding to inhaler, or in severe attack, or in status asthmaticus. Preparation, so status asthmaticus represents a severe form of asthma that is not ordinarily relieved by standard therapy. So even after nebulization, after giving whatever you need to give, it keeps on recurring. Not really recurring, but it is not actually resolving. So after 15 minutes, you reassess the patient, the bronchoconstriction are just there. So sometimes you might need to intervene by giving superior drug. So a superior drug in this context could be salbutamol in injectable form. Ordinarily in clinical practice, it is rare to encounter something like this, not the status asthmaticus, but this drug. but it can be used under these circumstances. So how do they come in terms of preparation? It can come in 500 microgram. That is 1 ml containing 1 microgram ampule. The dose can be 8 microgram per kg. So you can either give subcutaneous or IM after every 4 to 6 hours, usually 4 hourly, or 4 microgram per kg body weight in IV. So with the IV, it gives low, and it needs to be diluted with the dextrose or monosaline. So our recommendation is start with the IV, start with the subcutaneous or the IM. It seems to be much safer, and much safer and also effective, not in terms of symptoms resolution, but in terms of administration. So just considering you are sitting there for maybe up to 15 minutes or even up to 30 minutes, pushing an IV drug. So you'd rather do the subcutaneous or IM, unless the patient is having some other issues where the subcutaneous and the intramuscular injections might not be preferred. So for infusion, you can give 1 milligram. We have that exists in 1 microgram per ml. So you need to note, in obstetrics, it is used in premature labor. So the dose can be 100 to 250 microgram IV or IM. Repeat according to the response. So you know that we have circumstances that you might want to delay the labor. So one of the drugs that could be used are the salbutamol. So what are the adverse reactions that you'll anticipate with the salbutamol? Not so much different from the general adrenoreceptive drug. So these are the symptoms. It might cause some tremors due to stimulation of the beta receptors on the skeletal muscles, skeletal muscle cramps, urticaria. So these are very, very common. Urticaria, CNS effect, 2 agonists except ephedrine process the BBB poorly, so it might cause some hyperreactivity, suggesting that this salbutamol might have some CNS effects. So these include hyperreactivity, irritability, insomnia, weakness, dizziness, headaches, severe emotional disturbance. This is because also in the central nervous system, we have some adrenergic pathways that are normally activated by when the beta 2 receptors have been stimulated. So remember, this is an agonist. Can also have tachycardia, palpitations, and of course cardiac arrhythmias. So there might be tolerance or resistance due to prolonged use. So that is, effective bronchodilation may be reduced from 4 to 6 hours to 2 to 3 hours after treatment for several months. So the drug's responsiveness somehow reduces. Can also have some metabolic acidosis, hypokalemia, paradoxical bronchospasm, hypoxemia. Beta 2 agonists reduce arterial pressure, partial pressure of oxygen due to ventilation perfusion mismatch, nausea and vomiting. So those are tied to our Ventolin. Away from Ventolin, we also have other types of short-acting beta 2 agonists. So we also have terbutaline, a fairly common drug, has a similar effect and mechanism as salbutamol. It is available in tablets and inhalers and also subcutaneous injection. Just like salbutamol, subcutaneous injection also for this will be indicated for emergency treatment when maybe aerosol therapy is not available, or maybe has failed, or maybe when you are dealing with a more serious presentation. The uses likely to be similar. So uses and dose, uses and indication is just the same as for salbutamol. So those the tablets, we have 5 milligrams, which can be taken up to 4 times a day. So 3 to 4 times. Of course, this depends on the severity of the condition based on the patient. As inhaler, we have the metered aerosols. So one puff contains 0.25 milligrams. This can be given up to 8 times in 24 hours. The subcutaneous injection, this can give 0.25 milligrams up to 4 times a day. The duration of action is around 3 to 5 hours, unlike the salbutamol of 4 to 6 hours. So IV preparations, the indication will just be similar as to what we saw with the salbutamol. So another drug within this subcategory, the short-acting beta-2 agonist, we have the metoprolol. So they have effect and action similar to salbutamol, but of course the dose differ. The tablets are normally prepared in 20 milligrams, where it can be given 20 milligrams in adults 3 times a day. So adult or maybe people who are more than 9 years. Less than 9 years, they'll take half of it. So that is 10 milligrams for 3 times a day. We also have pabuterol, also in the same category. So dosage is normally 2 puffs after every 8 hours to a maximum of 12 puffs per 24 hours. So the inhalation solution can be given. That is 2 milligrams, normally for nebulization. We also have what we call phenonotorol. We have various preparation, can be available in tablets, inhalation, and syrups. So indications are pretty the same. So away from the short acting, we also have the long acting, where we've said that these are normally good for prevention. And we suggested that in the long acting, our major common drugs are the salmeterol and the formoterol. So while they are both long acting, we suggested that salmeterol are normally slow acting, while the formoterol are normally rapid acting, despite all of them being long acting beta-2 agonists. So that's suggesting that the formoterol might be much favorable to use in those who are having frequent attack, because to an extent they are also likely to be used as reliever. So our number one drug, salmeterol, or the brand name Cerevent. So this is a potent beta-2 adenoreceptor agonist, which is a variant of salbutamol. It has additional binding properties to the site, to the receptors, beta receptors. This results in slow onset and long duration of action, and has a high lipid solubility that permits it to dissolve in smooth muscles membrane, which acts as a slow release depot. It interacts with inhaled corticosteroid to improve the asthma control. It is administered by inhalation at the rate of 2 puffs after every 12 hours. So normally in some metered dose inhaler. So anytime you inhale, you are able to gauge that dose. So that is with the metered dose. It is normally useful in channel asthmatics and exercise-induced asthma. Because remember, for exercise-induced, you inhale before, so these are good preventer. Closely related, a long-acting formoterol, we've suggested that this is likely to be rapid. It's likely to have a rapid onset, where the features are likely just to be the same as salmeterol. The dose for adults and children over 6 years is normally 6 to 12 microgram. Can be given once or twice. You can increase to 24 microgram once a day or twice. So you will either upscale or downscale depending on the responsiveness. So a case scenario will be maybe you've had a client who has been nebulized, who maybe has been using Ventolin. So this time around, they are presenting with asthmatic attack. and maybe they tell you that in the past 3 weeks they've been having frequent attack. In every week, it's like almost every day they need to use their Ventolin to relieve their attack. So this time around, they are presenting with the attack, where you can either use Ventolin, or maybe if not responsive, you can use Ventolin nebulization. So maybe when you are encountering this patient after treating them, they'll be stable. So you need to ask yourself, is the Ventolin enough to prevent the frequent attacks that this patient has been experiencing? Your likely answer is likely to be no. This is because for the past 3 weeks, every day, these people have been experiencing asthmatic attack. So they'll actually require a superior drug to try to prevent. So you might either prescribe salmeterol or formoterol. So these people will be having, you use either of this. So this person, let's say you decided to go with the salmeterol. So this person will be inhaling salmeterol. Depending on the severity, maybe you want them to use it twice a day. So you prescribe salmeterol, maybe let's say 12 microgram BD for maybe a month until the time when you are supposed to review them, or maybe for 2 weeks until this time when you are supposed to review them. So in the process of using the salmeterol, if in between they have an attack, you can recommend that the patient use Ventolin. So these patients will be on 2 inhalers. Salmeterol for prevention that are normally used every day, and Ventolin that is likely to be used only when necessary. So if you compare salmeterol and formoterol, you are likely to pick formoterol. This is because when you're having the formoterol, there might not be a need for you to use Ventolin. This is because maybe the standard dose from formoterol, maybe you are prescribing to a patient twice, 12 or even 24 microgram for maybe 2 weeks or 1 month. And in between, maybe they inhaled it in the morning and they are supposed to take an evening dose. And maybe in between they have an attack. So they can again use the formoterol. This is because in as much as it's a long acting, it can also act rapidly. So formoterol, I'll say it can be a little bit superior. This is because it can also have a quick onset of action. So you might not really require the Ventolin. So these are some of the things that you should be able to note. So away from the sympathomimetic drugs, we also have other group of bronchodilators, as we suggested, the methylxanthines. So this was suggested that they normally inhibit the phosphodiesterase types of enzyme that will otherwise degrade the CAMP. The CAMP where we admitted was necessary for the bronchial muscle to achieve adequate not vasodilation, but rather bronchodilation. So when you are enhancing bronchodilation, of course, you are doing the opposite by minimizing the bronchoconstriction. So these drugs can be conveniently used to prevent or maybe relieve even the bronchoconstrictions. So the 3 most important methylxanthines are normally theophylline, theobromine, and the caffeine. Theophylline from tea, theobromine from cocoa, and caffeine from coffee. So these representing some form of stimulant. So they are having some stimulant aspect. So our priority will be the theophylline, which is likely to be the most common among the 3, or that which is majorly indicated for asthma use. So theophylline, the mechanism of action, it will just respect the mother group of the methylxanthines. So this will eventually relax the smooth muscle of the bronchi and the pulmonary blood vessel. This is because they inhibit the enzyme phosphodiesterase, which leads to an increase in intracellular CAMP. So CAMP is likely to activate some protein kinases with the resultant in form of muscle relaxation. So this is what you are likely to see. So what about the pharmacokinetic of theophylline? Absorption. Most forms are well absorbed and suppositories are normally poorly absorbed. Distribution. They are normally distributed throughout the extracellular fluid. They are normally metabolized into inactive compounds by the liver, majorly likely to be excreted with the renal. Of course, the indications, this is normally indicated for the treatment and prophylaxis of the bronchial asthma or the bronchospasm that could be associated with asthma and any disease that might present with lower respiratory tract obstruction. So these include the COPD, majorly the chronic bronchitis and the emphysema. So you need to be cautious in those who are having the cardiac disease. So remember, we had also some drugs that were revolving around the camp, the bipyridines. Hepatic disease, hepatic peptic disease. So remember, while we are covering the proton pump, or rather the secretion of hydrochloric acid. So some of the intrinsic cellular mechanism were with the increment of calcium and with the increment of the CAMP. So when the CAMP increases, we suggested that that is likely to result into a lot of proton pump translocation, leading to proton secretion or hydrogen secretion that might lead to hyperacidity. Cautious in hypoxia, epilepsy, pregnancy, lactation, elderly, dehydration, alcoholism, hyperthyroidism, and diabetes. It is contraindicated in peptic ulcers, epilepsy, hypersensitivity, and infants below 6 months. Drug interaction, increased plasma levels of norfloxacin, ciprofloxacin, erythromycin, insulin, verapamil, diltiazem, cimetidine, oral pills, pills. So this should be the contraceptive pills, and also the albendazole. They can also decrease the plasma level of drugs such as the carbamazepine, phenobarbital, phenytoin, and the rifampicin. Side effects, GIT disturbance. So this could be nausea and anorexia and vomiting, tachycardia, palpitations, tremor, can have insomnia, restlessness, dizziness, sweats, metallic tastes, some seizures, alopecia, and proteinuria. We also have the aminophylline. Amongst the three, aminophylline is likely to be the drug that you're likely to encounter more commonly, while theophylline are also normally there, but they normally tend to come in combination with ephedrine. So remember, we are suggesting franol in our introduction. So aminophylline as the drug is actually a mixture of theophylline and ethyl enediamine. So theophylline relaxes the smooth muscles. Other action of the theophylline are to increase in the rate and the force of cardiac muscle contractions and increases diuresis. So remember, this is all because of the CAMP. Pharmacokinetic, theophylline from the GIT is rapidly and completely absorbed. Theophylline enters the circulation and approximately 40% of it is normally bound to plasma protein, while the remainder is normally distributed throughout the body. So that representing the 60%. So the aminophylline is also a type of theophylline, only that it has another compound, the ethylene diamine. So the serum concentration of theophylline reaches the equilibrium with drug tissue concentration after 1 hour of injection. It can cross the placenta and pass into breast milk with no adverse implication. However, 85 to 90% of theophylline is metabolized in the liver and excreted in the urine rapidly. It has a half-life of around 8 hours. Elimination rate is reduced by the liver disease, of course, congestive cardiac failure, febrile illness, drug which reduce the rate of clearance, for example, cimetidine, erythromycin, quinolones, such as ciprofloxacins. You can have propranolol, allopurinol, influenza A vaccines, oral contraceptives, and low protein, high carbohydrate diets might also reduce the rate of clearance. Obesity is associated with a reduced elimination, while smoking, tobacco, and cannabis might enhance renal clearance. This is by inducing the hepatic synthesis. So when they are metabolized, they are likely to be cleared much. So these are some of the things that should be able to note to understand the dynamics in respect, or rather the pharmacokinetics of the drugs that might affect their effectiveness. So some drugs increases the rate of clearance, leading to reduced serum concentration, e.g. carbamazepine, that is the Tegretol, rifampicin, cigarette smoking, low carbohydrate, high protein diet, phenobarbital, and phenytoin. Mechanism of action, just is what we suggested. Pharmacodynamics, sometimes have effect on the CNS, so they can be stimulating drugs when it comes to the CNS. It have their effect on the kidney, cardiac, skeletal, and smooth muscles. So remember, courtesy of the camp. Theophylline has a marked action on the smooth muscles, as caffeines on the CNS. So what are these pharmacological pharmacodynamics effects that we might be able to see with the aminophylline? So methylxanthin produce mild cortical arousal. This is in the CNS with increased alertness and deferral of fatigue. It results in nervousness and insomnia. Very high dose causes medullary stimulation, convulsion, and even death. So the CNS side effects are tremors and nervousness. So you just need to know that this could be considered stimulative drugs with the CNS, whereby, of course, excessive stimulation of the neuronal pathway is likely to lead to convulsion. The convulsion, if not controlled, can, of course, have death, can result to death, that is. Cardiovascular effects. So methylxanthin have a direct positive goniotropic. Remember now, this is because you are enhancing the camp, and inotropic effect on the heart. They can cause an increased release of catecholamine that causes an increased vascular resistance, resulting into mild increase in blood pressure and moderate consumption. There is an increase in calcium influx through the camp when large doses are given, while low dose inhibits the presynaptic adenosine receptors, resulting in sinus tachycardia and increased cardiac output. So large doses will cause relaxation of vascular smooth muscle, except in the cerebral vessels, where they might cause some constrictions. They may reduce blood viscosity and reduce blood flow under some certain circumstances. So remember what we were suggesting with the platelets in relation to the CMP, whereby if CMP increases, platelets aggregation reduces. And what does that translate to blood? Of course, translate to reduced blood viscosity, because we have minimal chances of platelets aggregations. GIT effects will stimulate the secretion of both acid, gastric acid, and digestive juices. Kidneys, theophylline can act as a weak diuretic, which increases the glomerular filtration and reduces tubular sodium reabsorption. So when you are covering this, you might be having a thought that this drug might not be as suitable because of the many effects that we can see with the other system. Skeletal muscles, it might cause or strengthen contraception or contraction of the selected skeletal muscles, and can improve contractility of the diaphragm in patients with a chronic obstructive lung disease, and can reverse fatigue of the diaphragm in some subjects, so that this could be a plus. Smooth muscles produces relaxation of the airway smooth muscles and inhibit antigen-induced release of the histamines from the lungs. It has a known effect on the mucociliary transport. So what are the clinical indications? So in our context, of course, we are using this for bronchospasm, but we can also have some other use of the drugs. So aminophylline is normally used in the treatment of acute and chronic asthma and acute severe asthma. Theophylline has a narrow therapeutic window. So this is something that maybe might not be good. And hence it is important to check the serum level. So this is a spelling error, just correct this. Serum level, as toxic effects are related to plasma concentration. Improvement in pulmonary functions correlates with the plasma concentration. So if you increase the concentration of the dose, you're likely to have this toxic effect. So you should be cautious with the dosage. Plasma concentration of 15 milligrams is toxic. And it is likely to present with some headache, anxiety, nausea, anorexia, vomiting, abdominal pain. Plasma concentration of more than 40, now disastrous, can cause seizure, arrhythmias, which might be presented by GIT or neurological warnings symptoms. So plasma clearance varies, but the average is around 0.6 kg per minute. Children clear the theophylline much faster at 1.1 to 1.5 ml per kg per minute. Neonates and young infants have the lowest clearance. Liver disease reduces the clearance, so these are things that we discuss. Increased clearance can occur by inductance of hepatic enzymes, by cigarette smoking, or changes in that. So why are we introducing all these aspects? This is because aminophylline is one of the emergency drugs that are given when people present with bronchospasm. So bronchospasm, to an extent, sometimes it might depress the oxygen saturation level. So it means that sometimes the patient might require intensive care. So you'll be operating where you'll be in a state where you need to give adequate dose of aminophylline, while also acknowledging that you might also have all these other effects that might worsen the status of your patient that is in critical care. So all these are very important so that you are able to place your treatment into context while considering every aspect as it applies with the aminophylline. So drug interaction, erythromycin, ciprofloxacin, oral contraceptive, and allopurinol tend to enzyme inhibition, resulting in increased plasma concentration. So what in terms of dosage and preparation? So these can be available as tablets. This can be available as some IV injection. So normally 100 milligrams. Suppositories are also there, but they are the least reliable compared to the 3. So this is how you give 3 to 4 mg per kg, 6 hourly. So that's QID. Slowly IV, you will need to give it over 15 to 20 minutes. So you need to remember this part. So if you get the aminophylline and just inject it within a minute or within seconds, the patient is likely to have this toxic effect, sometimes even a collapse or conversion. So this is a drug that you need to give extremely slowly. So sometimes you can prolong it to even 30 minutes. Adverse effects, of course, not making sense considering the pharmacodynamics that we've suggested, but just read. Tachycardia, arrhythmias, nausea, diarrhea, headache, dehydration in children, convulsion, dysuria in all men, especially with BPH, due to relaxation of the destrusor muscles. Increase gastric secretion in PUD patient. Hyperglycemia and hypokalemia might also be some of the effects associated with it. So lastly, with the broncho drugs that, or rather the bronchodilators, away from the sympathomimetic methylxanthines, we also have the antimuscarinic. We said that Stimulation of the parasympathetic might result into bronchoconstrictions. So you need to use drugs that acts against the parasympathetic system, and conveniently are the preferable agents. So the autonomic nervous system, we suggested, will play a great role in normal and pathological lung functions. Antimuscarinic agents are also called anticholinergic or the cholinergic antagonist. We are dealing with the muscarinic receptors. So these are normally found in the parasympathetic system, in the postganglionic fiber, where it is normally acted upon by the acetylcholine that is likely to be released by the vagal nerve at their neuronal end, will activate the specific type of muscarinic receptors, specifically muscarinic 3, on the bronchial smooth muscles. So this is likely to cause some bronchoconstrictions. When you're using the antimuscarinic agents, they tend to block these receptors and bring some aspect or some amount of bronchodilatations. So these agents include atropine, not used nowadays because for this purpose. This is because atropine might affect many muscarinic receptors and have a lot of unwanted antimuscarinic or anticholinergic side effects. We have the ipratropium and the oxytropium. So the two are preferable, but among the two, between the two, this is the most common likely to encounter. So the mechanism of action, of course, we are blocking the vagal end, or we are blocking the muscarinic receptors. So we are otherwise achieving the not vaso, but bronchodilation. So clinical use, antimuscarinic agents are effective bronchodilators, and ipratropium bromide or ipratropium and oxytropium bromide or the oxytropium are very important synthetic analog of the atropine. So these are likely to have some less anticholinergic effect, or the patient might tolerate them more. So let's start with the ipratropium. So ipratropium can be delivered in high doses to muscarinic receptors in the airway because it is purely that is or negatively absorbed after inhalation and does not readily enter the CNS. So that could be an advantage. Unlike something like the atropine, when even given through inhalation, they can still be absorbed and give us a lot of anticholinergic effect systemically. So these are just likely to act locally on the M3, the muscarinic type 3 receptors, to cause bronchodilation. Ipratropium is usually combined with the beta-2 agonist to improve the efficacy. So this is even with the use of maybe some short acting such as albuterol, terbutaline, or salbutamol. So for example, we have a combivent combining salbutamol and ipratropium. So remember, these are bronchodilators. So when you are using two, you are likely to potentiate the effect. So it can be given as an inhaler, or it can be given as a nebulization. So this in nebulization, maybe you nebulize with the salbutamol and maybe not seem to be working. Sometimes you can use the combivent. In some places, we just have the combivent where you use this. We are likely to have favorable result compared to the salbutamol alone. So indication, this is indicated for reversible airway obstruction due to chronic bronchitis, emphysema, and rhinorrhea. So this is beneficial, having that we also have some muscarinic receptors on the upper respiratory tract. So meaning that During nebulization, it can also act on the upper respiratory airway to limit or to give us the anticholinergic effect in terms of uh, preventing excessive release or excessive secretion. So that's why it could be very important in the use of things like rhinorrhea. Precaution, those who are pregnant or who are having prostate hypertrophy. Dose administration, so 1 to 2 puffs per hourly, a maximum of 12 puffs in 24 hours. So just remember, 1 puff should be containing 8 micrograms. So you want to administer averagely 36 at a go. Most patients respond after 2 puffs within minutes, within a minute to 30 minutes. 75 to 85 of the maximal bronchodilation has been attained. So this is what we are likely to see. Adult dose is around 100 to 500 microgram QID. Children 3 to 14 years, 100 to 500 microgram up to 3 times. Adverse effects, it might cause dryness of the oropharynx. So remember, we suggested that it can also act on the upper respiratory tract to cause some reduction in terms of secretion of mucus of the fluid. So the dryness can lead to irritation, can lead to dry mouth, dizziness, constipation, urinary retention, exacerbation of the symptoms. So that is with the bronchodilators. So we also have some other drugs. So just in brief, some other drugs that are very also important in the use of asthmatic attack. We also have what you can call the leukotriene inhibitors or the leukotriene pathway inhibitors. Leukotrienes are derived from the arachidonic acid, which is synthesized by a variety of inflammatory cells. So remember, we have the leukotriene in our pathophysiology, was playing a very important role in causing some form of bronchial secretion and also bronchospasm. So if you have a drug that negates this or minimizing their availability, it can also be very important in negating bronchoconstrictions. So we have the calcium channel blockers. So this LEMS example, majorly Montelukast. We have many types. You have Zafilukast, Azileuton. So you can read more on this. Most of the time not used, but it can also be used, calcium channel blockers. So this cell function depends to some degree on the movement of calcium into the cells. So calcium channel blockers, e.g. nifedipine and verapamil, when given via inhalation, may have significant inhibitory effect on the bronchoconstriction. So they can also be used as bronchodilators. So remember, these were the drugs that we are using as vasodilators. So we also have the anti-IgE antibodies. So remember, once we've activated the memory cells or the plasma, plasma cells, so they responded by production of the IgE, which will act on the mast cells to produce some of the cytokines such as histamine and leukotriene. So you using drugs that prevent the IgE can also be very important. So anti-IgE inhibits the binding of immunoglobulin type A to mast cells and other inflammatory cells, and therefore inhibiting or rather minimizing the bronchoconstriction. So example of this include omalizumab. So you can also read more on this. So the last term with the drugs that you can use in the treatment of asthma. So we've had the summary of the major classes of the drugs that are normally used. So we've also managed to suggest some accent on how you can use these drugs. So this table over here or this image represents a treatment algorithm. So this suggesting how a clinician is likely to administer this drug. So which are the drugs that are normally preferred? So we have various steps. So we'll elaborate this more in internal medicine, but it is just good for us to know and start practicing. it early. So we have step 1, step 2, step 3, step 4, step 5, step 6, or we are following some logical approach. So by in step 1, you are assuming that maybe you're dealing with patient who maybe the asthma is not severe. So as you move towards this side from step 1 all the way from step 6, you are also assuming that the severity of the asthma is somehow increasing, or maybe the control with your drug is not as effective. So if the control with the drugs is not as effective, you need to add another compound. And as we move up the ladder, we are adding some other drugs. So maybe somebody who is having some intermittent asthma, which they're having on and off attacks. So maybe they might prefer SABA, the short-acting beta agonist drugs. Example, albuterol, terbutaline, salbutamol, and others. So these are only given when necessary, whenever these patients are having attack. So maybe this could be patients that maybe are having one attack after 3 months, or they may even forget if they are asthmatic. So they should just have this just in case. When the attack proves to be much frequent, they might need some preventive drugs. So one of the preventive drugs could be a low-dose inhaled corticosteroid. And of course, they'll still be having this to use it when necessary. So alternative to the low-dose corticosteroid could be this cromolyn, the leukotrienes, nidocromil, or the theophylline. When maybe not acting adequately, you might also add some other drug for prevention. So on top of your SABA, low-dose inhaled corticosteroid, you might add a LABA. So LABA represents the long-acting beta agonist. We suggested majorly we have the salmeterol or the formoterol. And of course, when there's in between, when there's an attack, they can use their short-acting beta agonist. Well, if they are having the formoterol, they might not need it. So maybe assume you've given this, and then after review, the frequency of attack is still the same. So you might increase the dosage of your inhaled corticosteroid to medium, and still maintain your LABA and maintain your SABA to use when necessary. If not responsive, you add the dose of the corticosteroid to high dosage LABA, and of course, you are still maintaining a SABA. So these are just some alternatives. So not normally first lines, but they can be used. If not responsive, again, you maintain the high dosage LABA, and now this is where you might want to use the oral corticosteroid. So in the clinical practice or in the over-the-counter, most patients will be using these drugs wrongly. So whereby because maybe their asthma is intermittent, they'll be using oral prednisolone. So they need to know that this is not right, and they'll be exposing themselves to a lot of side effects that you can get with either corticosteroid or with the cortisone. So they only use this as a last resort where this most of everything is not working. So that is good to know. And we suggested that education will also be part and parcel in terms of treatment. So most patients who are asthmatic may not be on drugs, not because they don't know, but this is because they could be having some form of stigma. So stigma stemming from some form of misinformation in terms of myths. So you might meet a patient who thinks that when they use an inhaler, it equals some form of weakness. So they might see him as a weak person. Or sometimes when you are using inhaler, it might give them the perception that the disease is really severe. It might give them the perception that the disease is severe. So you just need to deconstruct this and tell them that inhaler, it is just a way of drug delivery that minimizes systemic side effects. So somebody using oral and somebody using inhaler does not mean that the person using inhaler, their disease is severe, but they are using just this form of delivery to minimize a lot of systemic side effects that might not even be wanted by them. So these are some of the simple things that you should be able to tell them. So this is the end of our brief asthma. Next we'll be covering the respiratory stimulants, treatment of pulmonary edema, and lastly with the oxygen therapy that should mark the end of our respiratory pharmacology.